will be doing that role. But let me introduce you. So Ricardo Costa is someone I've known for a long time. Ricardo, I think we did our fellowships together in Milano, right? A long time ago. Neither of us, I don't think either of us had kids back then. So we've known each other a long time. And Ricardo and me, we share many things in common, but one of the things we share in common is our passion for bifurcations and trying to improve our outcome bifurcations. So I've learned so much from Ricardo over the years about IVUS and intracoronary imaging and how we can use it to improve our bifurcation outcomes. And so, Ricardo, it's an honor and pleasure to have you present to us and to learn from you again.
Thank you, Azim. Such a great pleasure to be here with you and your fellows and colleagues. And likewise, we share a long history with our master, Antonio Colombo, and we have learned so much. And not only me, but the entire interventional cardiology has getting to learn so much with you, with your great work and great contributions you have been done. And we're really glad to see this CAT conference, which is getting to be known throughout the world. And for me, it's just a great honor and pleasure to be here and to contribute and to discuss with you as well about bifurcations and these complex techniques that we are more and more using on a daily basis in the cath labs.
Fantastic. We look forward to it.
Hello, Dr. Costa and Dr. Latif. I'm here. Thank you.
Great. So this is Miguel Alvarez, he just finished his interventional fellowship with us and is now a junior attending who still works with us on a regular basis. So he's going to help us and challenge us with questions at the end. Okay.
Excellent.
Yeah.
Feel free to share your slides and start, Ricardo.
Okay, I'm just going to share here my slides. Here we go. Can you see them?
Yes, we can.
Okay, excellent. So the topic here is elective complex approach to bifurcation PCI, when to consider and how to do it. First of all, it's always great to remember when we're dealing with bifurcations, why is it complex or why does it can be complex? And basically bifurcation PCI outcome is directly related to the fate of the side branch, and that could be happening during procedure and also in the long-term follow-up. What can happen during the side branch compromise during procedure? We can deal with dissections, impaired flow, suboptimal result, how to assess that. And the worst thing that we don't want to have it is an occlusion of an important side branch. In the late follow-up, restenosis, that can be challenging to treat. And the risk of the side branch compromise, technically speaking, can be somewhat controlled if you have a guide wire in the side branch. Should we avoid the pre-dilatation, depending on what we plan to do it? Stent sizing, we should always size according to the distal reference, then to perform POT to avoid carina shift. Should we do always final kissing balloon? Some previous data suggested yes, but this was prior to POT. Now some more recent data, it's controversial. And also we should be always have in mind the anatomical morphological aspects of the complexity of the bifurcation to plan the procedure. So the evidence favors provisional approach. Everybody knows that. So how does it perform in lesion with different degrees of complexity? That's the big question. So here we have some different degrees of bifurcation lesion complexity. So this is a true non-complex, I would say, lesion. It's an important side branch, not that much disease. The disease is more the proximal part of the bifurcation. And final result with a provisional approach, stent in the main vessel, it's very, very straightforward, no issues. Then we have a longer lesion in the side branch here, not that severe though, but a more long stenosis. And then after stent in the main vessel, provisional approach, we see a pinched branch that does not recover well with the kissing balloon. Then we have to cross over for 2 stents, and this is the type of result we get. Then we can have this kind of complex, a very, very diseased diagonal branch in this LAD bifurcation. After Stenting the main vessel with provisional approach, we have an occlusion of the side branch, so already identify that should not be a good idea. We try to reaccess this branch, very difficult, very challenging. After spending a long time here, you're able to do it after multiple attempts, but then you have dilatation of the side branch, and then you deal with an occlusion, a dissection of this branch still with impaired flow. In this case, you're able to have a stent and then have a good final result, but very laborious. And then the worst case scenario, we have this very important branch, severe disease, long lesion, significant stenosis, and then even having a wire there, this got occluded at the end of the procedure. This patient will evolve with STEMI and cardiac heart failure after that. Very, very unfortunate situation. So it is okay to leave a suboptimal angiographic result in the side branch. See here we have a major diagonal branch in the proximal LAD with a significant disease at the ostium. Then a provisional approach is performed. There's an okay result with a good flow. And if we apply the Nordic criteria, which is basically I have a TIMI3 flow at the end of procedure in this very important side branch, this patient does not recover well after 2 months. He has an ACS, and here we can see a worsening of the osteolocation. And then this requires a new treatment. There's a TLR, there's a PCI failure. We want to avoid that. That's a DS implanted here, and then we have to touch also the LED, which was already somewhat stabilized after stent in the first procedure. This patient, after 2 months again, he also developed new symptoms. At the end of the day, he has to be sent to CABG. And also the late restenosis, even though with a provisional approach, we have this very acceptable result in this diagonal branch after stent in the main vessel and just balloon in the side branch. This patient comes at 9 months with a pinched restenosis, stenosis with the restenosis just at the osteolocation. And again, dealing with that, you're always going to have the chance to compromise the results in the main vessel in the LAD. So the question is, which bifurcation should not be approached with provisional side branch stenting? Are there any evidence for that? Which bifurcation lesions are at higher risk to fail with provisional side branch stenting? So the wide variability in bifurcation anatomy already tells us that not every technique can be applied in all bifurcation lesions. And that speaks mainly if you want to say, okay, a more simple approach versus a more complex approach. We had this study, Zin will remember that, we called it Inside One by the time we were together in Milan, and also with the collaboration and the CRF group as well as Dante Pazzanesi. And this was a registry conducted with 74 bifurcation lesions with clinical follow-up more than 6 months. So in these 68 patients, we have diabetes in 1/3, we had prior MI 32%, and prior PCI half of the patients. I would highlight 1/3 was also left main bifurcation. This was more than a decade ago. Most of the lesions were de novo lesions. And by the Medina classification, we have more than 85% of cases as considered to be true bifurcation lesions or more complex lesions. This is some of the procedure data. Single stenting was done in 41% of the cases, double stenting 59%. See that the single post-dilatation in the main vessel was 58%. This is prior to POT. A single side branch post-dilatation was 92%, and final kissing balloon was 96%. Here, as you expect, the stent of the side branch was, of course, smaller, and also the balloon, but pressure was also high. And interestingly, these procedures were guided by IVOS. Around 20% of the cases will come back after a very good angiographic result, but after doing IVOS, we see there was actually suboptimal in some aspect. So we have to come back and then perform a new dilatation or even plant a new stent. And for the side branch itself, 50% of the cases. Out of hospital major events, we have 13.6% TLR and 13.7% 6% non-TVR, TVR 6.1%, overall MACE accounting 22.7%. And interestingly, when we compare the stented side branch versus a non-stented side branch, the stented side branch were longer lesions, larger vessels with a more severe disease. When we compare the IVUS analysis, we also dealing with more severe stenosis and more longer lesions also detected by IVUS with more significant negative remodeling at the osteo location. So some very important observations from this registry were that stenting, a more complex approach, was related to vessel size, lesion length, and lesion distribution within the side branch. So this study, initial study, led to a second study that was, these were all mechanistic studies, small but mechanistic studies. We called the INSIGHT 2, which was a randomized, trying to get more severe lesions and also lesions in the side branch extending from its osteon, and then to compare provisional versus any double stenting technique. This was all IVUS guided procedures. We have some hypotheses that these lesions should benefit with double stenting as compared to single stenting or provisional stenting approach. This is some examples of the type of lesions that we included. So we can see side branches were quite compromised and also longer lesions as compared to previous studies. Here's some other examples. And what we did here, we thought that predilatation should be performed in the side branch due to the severity of the lesion. If you have a successful predilatation, then lesions should be randomized for one versus the other technique. However, if you have unsuccessful predilatation with some specific criteria, you should go ahead with a double stent, not even consider to do provisional stenting. What was the criteria for failure? This was quite standard for different studies, like the Cactus performed in Milan, stenosis more than 50%, TIMI flow less than 3, and dissection in the side branch. So side branch failure was assessed at 3 different time points. We had a predilatation, crossover from single to double stenting, and also angiographic stenosis at 9-month follow-up. So first, at predilatation, this is one example. After predilatation, one would expect a significant dissection. This patient was treated with mini crush technique, and this was angiographic follow-up at 9 months with a great, well-sustained result. The only predictor that were identified as predict for a successful predilatation was the percent diameter stenosis. As you can see in this raw curve, this was diameter stenosis above 85% by QCA. Crossover from single to double stenting, so the 27 patients randomized to each group by intention to treat. We can see here the lesion length by QCA around 8 millimeters, vessel size around 2.6%, diameter stenosis by QCA around 75%. In terms of the techniques, we have a crossover of close to 20% from single stent with a provisional approach ended up being treated with double stenting. This is one case example. We see LAD with this major side branch, a ulcerated LAD. By IVUS, this was a ruptured plaque in this location into the LAD. This was the reference, 4 millimeters proximal, 3 millimeters distal. Here we can see this ulcerated lesion in a different view, and in the side branch, a calcified osteal lesion with a close to 2.7 millimeter in reference. Predilatation was performed. This was the result we thought was acceptable for randomization, and it was randomized to single stenting. This was final result after stenting and optimization with kissing balloon, stent in the main vessel, and we still see a residual stenosis about 90% of the osteal side branch. So this met the criteria for crossover. We performed a tap technique, stenting the side branch, and this was kissing balloon, and this was a suboptimal result by IVUS, not by angio, I would say. And you see by IVUS, not a good apposition, proximal end of the stent, and the expansion in the side branch less than optimal as well. So we come back, this support procedure, kissing balloon, and this was not very different result by angio, but by IVUS, yes, that's a good apposition, and expansion, now we above 80%, which should be the minimum target when we guiding by imaging. And this was the follow-up at 9 months with a good, well-sustained result. What were the predictors that we found for side branch failure with provisional approach? Lesion length, and severity of the lesion, and by IVUS also eccentricity was one of the interesting predictors that we found. The plaque towards the takeoff of the side branch was one predictor. In the multivariate model, the eccentricity by IVUS was the one predictor found as compared to the others. The final minimum lumen area was the endpoint for this study. So as you expect, of course, double stenting would offer a larger area at post-procedure in the osteal location of the side branch. But very importantly, this difference is sustained at 9-month follow-up, and that speaks for a less restenosis found in the side branch as compared to the with double stent as compared to single stenting. In terms of the restenosis location, most of them were found at the osteal location, and this we see systematically with any technique in any study. So that location where we should concentrate our efforts to get an optimal result. And if you guide it by IVUS, you should guarantee you getting a good luminal area at the end of the procedure in this particular location. When we perform the analysis per treatment received, we're going to see that this difference is even bigger, and both at final and 9-month angiographic follow-up and invasive as well with IVUS, more pronounced in terms of the lumen area, the sidebrain osteal location. And at 9-month restenosis, we see a significant difference. So if you're dealing with this kind of complexity, if you're skipping the patients that did not have a successful pre-dilatation, you're still going to have 30% restenosis in the osteal the side branch if you're doing single stenting, as compared to 3.3% if you're doing double stenting in procedures guided by IVUS. And then angiographic restenosis at 9-month follow-up, these were the predictors. So double stenting was a what's so-called protective for not occurring recurrences in the side branch location. And the minimum lumen area at side branch by IVUS was also a predictor identified. This study was not powered for clinical endpoints, so we did not see difference at 12-month follow-up. But in terms of the mechanistics we found, it was interesting to see the predictors of side branch failure were severe stenosis and complex morphology, and also larger luminal dimensions at the osteal location treated with DES. We are all used to use the Medina classification, which is genial the way they have created this 111 or 101 in terms of the 3 location segment, anatomical locations of the bifurcation. And that many have been used to say how complex it is, the lesion, and try to use that information to plan the procedure. However, if we can see this is a poor stratifier. See these 2 examples. They have the same location. They are LED diagonals. They have proximal segment involvement. They're all significant lesions, but a completely different complexity due to the degree and extent of the disease. And if you take the data from the pool data from the Nordic 1 and BBC 1, perhaps the ones that mostly have impact our guidelines towards provisional in most of the lesions, they even say the true bifurcation lesions also are benefited by it favors a simple approach. However, how much of this complexity has been represented in these studies? So the predictors of side branch occlusion that are not accounted in classifications like the Medina classification are many. And I can summarize here the degree of stenosis. Of course, 99% is different from 50%. A large plaque burden, an eccentric distribution, a diffuse lesion extending from the sideband osteon, significant calcification tortuosity, a shallow angle between branches, an impaired flow at baseline, and vessel size and corresponding myocardial territory should also be considered how much we're going to invest and care about the branch and how much we should optimize the result. The data from the COBIS-2 registry, more than 2,000 patients, the predicted side branch occlusion, which occurred in 8.4% of cases, also pre-procedure diameter stenosis, a proximal main vessel diameter stenosis, the lesion length in the side branch, and also ACS as a clinical presentation. Full eye hospital registry, also the predictors identified for occlusion. Plaque located on the same side as side branch, like eccentricity, as we found in the IVO studies, the TIMI flow before main vessel stenting, and also the degree of stenosis in the side branch before the main vessel stenting. Important geographic parameters for decision making beyond the Medina classification. So we need to have all this in mind when we plan the procedure. The side branch size and importance. If you're dealing with a left main bifurcation with a large circumflex, dominant circumflex, this should be much important taken into account in the strategy to be taken, and perhaps a strategy that allows you to guarantee you patency of this branch should be taken into consideration if you have a higher risk for occlusion. The degree of stenosis at each location, lesion length in the side branch, calcium, tortuosity, thrombus, whether in the main vessel or the side branch, angulation between branches, plaque burden distribution in main vessel and side branch, and also the coronary flow in these both branches. There's some important studies. This is from the DK Crush 5 series, DK Crush series, but this DK Crush 5 that compare a double stenting technique versus a provisional stenting approach in left main bifurcations, complex left main bifurcations. And we have seen benefit now in terms of clinical endpoints with a more complex approach, DK Crush in this case, as compared to provisional in terms of target lesion failure at the long-term follow-up. These criteria, some of these criteria we have identified in these IVO studies and others have identified in different registry studies. They have been compiled in what we call the definition criteria, also based on the definition 1 study, the predictors of side branch failure, and they have been applied as a discriminator for the technique to be considered in the definition 2 study. So basically, a major criteria has been identified. So patients to be included in the definition 2 studies, they have to have a major criteria. Left main was lesion length in the side branch more than 10 millimeters, stenosis more than 70%, and in non-left main, a lesion length in the side branch more than 10 millimeters and a side branch more than 90%, plus any other 2 minor criteria, which was mild calcification, more than mild calcification, multiple lesions, more here extending the coronary disease itself, not the bifurcation itself, but anyhow, this was included. Extreme angulations in bifurcations, and main vessel less than 2.5 millimeters, meaning that a much larger side branch was there, main vessel lesion length more than 25 millimeters, and a thrombus containing lesion. So if they have this criteria, then it was applied for a provisional versus a 2 stenting group, any technique for the 2 stenting. And interesting to see that after 1 year, benefits were observed towards 2 stents in terms of significantly reduced rates of TLR, target vessel MI, and also target lesion failure. So somewhat validating that a much higher complexity now based on this definition criteria was also beneficial to have a complex approach as compared to a more simple provisional approach. So some technical considerations in bifurcation with large side branch irrigating significant amount of myocardium. Do not attempt provisional strategy if a side branch is at great risk for occlusion. Save some time and stress. Long lesions, severe osteostenosis, sharp disangulation, heavy calcification, eccentricity, severe and long stenosis in the parent vessel with large plaque burden are some of the most important criteria to be considered. Consider side branch predilatation in this scenario. If unsuccessful, go for elective double stenting strategy with primary stent implantation in the side branch. You're going to avoid time and stress, and optimize results with imaging guidance. Thank you so much for your attention.
Ricardo, thank you so much. That was great. It gives us lots of time for questions as well, and I'm sure there will be. But I'm going to start maybe while Miguel comes on, and I'm sure Miguel has a lot of questions.
Yeah, I think I can, if I can just allow me here, I have a second part with technique, okay, that we can use. But since I know this can have a lot of questions, we can open now to have questions as you want. And if we still have some time, then I can show the second part of this presentation with case examples and some specifics about techniques.
Yeah, I think that would be great. I think it would be great. Let's just, because I'm sure there's some questions here about the tech, about what you've presented, and then we can go through the technique a little bit. Maybe show as much time as we have, show one or two, a couple of cases. So Miguel, if you can come off mute as well and put your mic on. So I'm going to start first. Ricardo, so we've been, this whole discussion, 1 versus 2 stents, we've been doing it as long as I can remember. We did it in the bare metal stent era. We found bare metal stents were bad, but since DES have become available, we've been doing it, and we've gone, from one extreme to another, it seems. So from doing a lot of 2 stenting, okay, when we invented Crush, to now where groups like the European Bifurcation Club, was very well respected, really try and discourage us from doing 2 stenting, right? And they discourage us based on the clinical data, the 6 randomized studies that showed no benefit from double stenting. So most of them didn't even show any harm, but they showed no benefit, right? So whether it was Cactus or the Nordic studies or BBC, there was really no benefit. So someone could argue, why are we now talking, why are you suggesting we should be doing 2 stents? I know that's not what you're suggesting, but I wanted you just to clarify why those studies don't really apply to what you're saying and to what definition is saying.
Yeah, if you want to try to simplify this question based on this, let's say a first wave of studies comparing single versus double stenting. For example, BBC One and the Nordic, even if you have a significant representation of a let's say complex bifurcation according to the Medina classification based on a visual estimation, if you go for the QCA data for these studies, you're going to see that the mean diameter stenosis in the side branch was not even 50%. So we were treating lesions with complex approach that we should not be treating at all. Nowadays, no one would consider to put a stent in the side branch just because they have like a 40-50% stenosis there. And this was a large representation of these, let's say, complex bifurcations in these particular studies. Adding to that, we're using first generation DS, which were much thicker struts as compared to what we have now. So if you have situation where you have a crush stenting or some more prone to deformation, distortion of the struts according to the technique that were applied, you also will be more likely to have recurrences like stent thrombosis. Remember, we saw that study from Angela Hoye by the time that the stent thrombosis with the classic crush stenting was around 4.5%. So this, of course, was completely unacceptable. And also, the technique has much evolved from that time to this time. Why crush was so widely accepted in our community? Because somewhat it guarantees a patency of the side branch with a modified T technique. So you would cover completely the osteo, the side branch, and then you could work, let's say, without the risk of losing the side branch. But then you have to optimize the technique, and optimization with thicker stents and a longer crushed segment was also challenging by the time with the innovations. And I think Dickey Crush was a great response to that, because you just create a new ostium of the side branch. And then after that, you'd stent the main vessel, so you avoid all the distortions under expansions and incomplete position this particular location. That represents why we see much better results with double stenting. And also, finally, no doubt that because of this, improvement of the technique, the materials, now we treat a much more complex lesion than subsets in a regular basis. So this type of lesions, we show some examples here, they were not treated by the time, and no one will consider to randomize lesions with that complexity by the time.
Yeah, absolutely. I think that's a great point. We did the cactus study, as you know, and I have a couple of tables, and we've published where we look at the QCA data of the different studies, and then besides the percentage, the mean percentage stenosis for the side branches that were stented were like 50% or less was the percentage diameter stenosis, but also the lesion lengths were like 5 millimeters, right? 4 or 5 millimeters. So they were not very complex. So the operators had to feel comfortable doing a provisional strategy on that case. I'll pass it on to you, Miguel. I don't want to go ahead. You're on mute, Miguel.
Oh, can you hear me now?
Yeah.
Good morning. Thank you. That was a great talk. For a young attending or young interventionalist like me who hasn't been around for all the iterations, it looks like it's decay crush really what has made a difference in terms of outcomes when it comes to provisional versus dedicated to stent strategy. Don't you think that's the case? Because even in the definition trial, the use of IVUS was only about 20%.
Yeah, that's a good question. Why decay crush was so beneficial, and maybe even in studies comparing with other double stenting techniques like the decay crush 3, which compare against clot. There's some speculation about that. If you look at the DK Crush series, they're mostly performed, not say totally performed, in Asia in centers very well trained with this technique. This technique can be laborious. There's a lot of steps. You need to make sure that you're following, you're doing the steps accurately, and you're optimizing each part of this technique to get the best result. We are not sure how much the other techniques were so well applied in these studies in this center. So I think that's the first point. We're going to have now the studies from the EBC main. There's also another study now being conducted in Europe that I think we're going to have an answer to that, because now for the first time out of Asia, they're going to be dealing with this type of complexity, and they're going to do comparing provisional versus double stenting, not only the DK crush, but double stenting, and we believe DK crush is going to be well represented. So we're going to see out of Asia, how does that perform? Is that similar results or not? So that's, I think it's a first point. For anyone who does complex bifurcations, and we have an expert here, Azim, one of the masters in bifurcation and complex PCI, I think you can really get good results if you optimize, if you have image guidance, and if you take care of the three key, let's say, predictors for failure in PCI, which is stent under expansion, incomplete strata position, incomplete lesion coverage. If you're avoiding that, if you're guiding your procedure, if you're using whether clot, or if you're doing a tap, or if you're doing a DK crush, I think you are able to optimize in the way that you can still have good results in the tech. I like DK crush. I use DK crush a lot in my practice, but I'm not fully convinced that I'm only going to get good results with DK crush. I think with other techniques, I can get good results as well if I optimize in the same way I optimize DK crush.
I see.
I don't know if you agree with this.
Absolutely. I couldn't have summarized it better. And I think, particularly how you summarize those three factors of stent failure. The one thing I continue to tell our fellows is that, they need to know how to use a double stent technique, but it carries a responsibility. So if you need to be meticulous when you put stents in any case, you need to be even more meticulous when you do double stenting. Because one of the things we showed early on from the Milan data was, when Crush came out, and you wouldn't know this, Miguel, everybody was doing it. It was just easy to do. But the first 1.5 years, almost 2 years that people were doing Crush, no one did kissing inflation. They just did a Crush. Okay. And then suddenly we started seeing a lot of stent thrombosis and restenosis. We then introduced kissing inflation, and suddenly it dropped by like 60%, the events. Then a couple of years, like a year or two after that, we introduced a 2-step final kissing inflation, where we did very high pressure inflation in the side branch ostium, followed by kissing, and the event rates dropped even further. And it was just a very nice example how the technique, okay, is extremely important when you do 2 stents. I think what I like about DK, and I agree with Ricardo, is I think if you're going to do complex PCI, you need to have more than one technique under your armamentarium. But to learn one well before learning another one, right? There are lots of steps in DK, but I do think it does facilitate those steps by doing that first kissing. Because when we looked at data, and you look at the data like BBC1, which was a study done in the United Kingdom, where as a result of this study in the United Kingdom, they hate the word crush. But if you looked at it, there was a lot of cases where there was no final kissing inflation done because they were unable to recross at the end. And that's what DK crush does feel, the first kiss. It makes the final kiss easier to do.
Right.
And I just want to highlight one point. I don't think all double stenting techniques are the same. And I think one of the great advantages of crush or DK crush is that you don't have to recross a stent to preserve patency.
Right.
The branches. You don't have to do that. With Clot, you have to do that. With TAP, you have to do that. With any other technique, you have to do that. So I think there is a special role for DK crush in very, very complex subsets where you have much high risk for side branch or branch occlusion. And I think that's why, if I have to pick one technique, you should know how to do it. You should know the steps, because that's the one that can save you in situations that you might have problems on reaccessing one of the branches.
Right, definitely. Okay, there is so if you had to pick, what is more important, angiographic stenosis or TIMI flow of the site? You have angiographic stenosis of 80%, but the TIMI flow is 3. Would you just not do crossover to stent strategy?
If I have to pick one, I would say diameter stenosis, but there's no study comparing that. And usually you're not going to have a impaired flow for without reason. So sometimes you have a suboccluded stenosis and then you have a impaired flow. And the mechanism here is not impaired flow. The primary is this diameter stenosis. So I think that's the one most important.
Right. What do you think is the role, or what will be the role of drug-coated balloons in side branch treatment?
Yeah, very good point. There's some studies already there, and that's a new studies also being conducted. I think, my personal opinion, I see a great role, not acutely, but in the long-term follow-up. As I show in the data from our study with the mechanistic study with IVUS, besides have a good angiographic final result, and even intravascular ultrasound acceptable result in the side branch with a single stenting approach, you're still going to have 30% angiographic restenosis. Are they all important? Do you need to treat all of that? All of that going to lead to TLR? Probably no. Depends on how important the side branch is. But nevertheless, nobody wants to deal with that if you have to. So I think drug-coated balloon can be an answer for that in terms of a sustained result into a side branch, not stented side branch, to get a good result with provisional approach.
Mm-hmm. What about physiology testing, FFR, RFR in the side branch to decide whether you stent or not?
Yeah, I see a good role, a great role. This has been already demonstrated first by the classic studies by Ku, and also different groups have also tested that. But I'll just highlight one aspect of these studies. These were side branches that didn't have significant disease to begin with. So they became compromised throughout the procedure due to carina shift, due to plaque shift, due to spasm after a kissing balloon inflation. So in these particular cases, I think it can be well applied, and most of the cases we have learned that's going to defer further treatment into that branch, and I think that's a good thing. But if you're dealing with a complex lesion, with a significant stenosis, with a long lesion to begin with in the side branch, I don't see any role of FFR after, throughout the procedure, or even after the procedure, because you have a plaque there that even though you have a acceptable result by angio, you're going to be more likely to have recurrences in the late follow-up.
Okay. If you do provisional stenting in a patient, they return a few months later with angina, but it's a stable picture, and you do an angiogram, you see that the side branch is the problem. It's suboccluded or perhaps very stenotic. How much do you go after these side branches, and how much do you generally recommend to just leave them alone?
Well, here is the clinical indication. If you have patients coming to the cath lab, if you don't do it, coming to the hospital, if you don't do anything, the patient is going to come back, in a few months, and then it's going to be coming to the ER until you do something, or he's going to change his physician. So I think you have to deal with that. I think the only reason for you not to approach a compromised side branch, whether it's acute or in the long-term follow-up, is if you don't have any clinical repercussion. If you have clinical repercussion, you have to treat that. How to treat that depends. If you have a very, very osteofocal lesion, maybe just ballooning and then DCB, I think would be a good idea. I'll try to avoid as much as I can to touch and further treatment in the main vessel if there's a good result. If you have to stent that, let's say like a tap, a staged tap, like we have to say, a provisional T stenting in the stage fashion, I think you can deal with that. But then you're going to touch the main vessel, and you're going to be more likely to also have recurrence in the main vessel. Some people would say, okay, I have a good result in the main vessel, I'm just going to put a DCB here, I'm going to put a stent, I'm going to do a kissing balloon with a DCB. Maybe that's helpful, but we don't have data to support that, to use on a regular basis.
Mm-hmm. Okay, I saw Dr. Latif do this once when we were treating a left main bifurcation, very deceased circ. It was a dedicated, we were stenting the main branch, and he trapped a balloon behind the tail wire in the side branch to rescue if needed in case of occlusion of the side branch. Do you ever do this, and when do you do it?
Well, I think that's a technique well described. It's a rescue technique. And if you're dealing with a major side branch that you want to take chances to lose a side branch like that, and it makes all the sense to use in the left main bifurcation. And if you have anatomical factors that with high risk for occlusion, I think that's one of the approaches that you might use in order to don't take chances on losing that side branch, even though you're going to have to, at one point, recross through the struts to have the optimal treatment there, but at least you don't lose patency. And I think in this type of much higher complexity, that's a good thing to know how to do it and to use if needed.
What is the trick there? Do you use a longer balloon, a smaller balloon?
You can use a longer balloon with a very, very a smaller diameter. I think that's what we have used in our practice when needed. Azim, do you agree?
Yeah, completely. It's very uncommon that I need to do it. I must admit, there's maybe like one case a year where, and you may ask, if you're worried about it, why am I just not stenting the side branch to begin with, right? And usually it's a case where either I don't want to stent the side branch because there's a lot of maybe more distal disease, or more usually because it's like a left main with a 90-degree angle or larger, where I don't really want to do a crush technique, where we know that, one of the predictors of restenosis with DK crush is angles above 70. Okay, and if you have a nice 90-degree angle, a T is so much better, or a tap is so much better. But I'm worried, will I lose it? So what I do is I leave a 2 millimeter or 2.5 millimeter balloon that's longish, so that the trick is it has to extend proximally outside the main branch stent. Okay, it can't be completely trapped. I also then I don't deploy the stent at very high pressure. I just go to nominal pressure. Okay, and then if the side branch is open, then I'll do my pot. I'll pull the side branch balloon wire, and then I'll do a pot to oppose the proximal main branch stent. I think what Ziad is asking and Ziad, thank you for joining. Ziad's a very experienced operator, and so I'm always honored that he decides to join us. What Ziad's asking, and this has happened a couple of times to us, is you go for a provisional approach, okay? You put your stent in, you have a wire in the side branch, and then the side branch goes down, okay? No flow, okay? With your jailed wire. Now there it is described, you can do it if you take like a 1.0 balloon, some of these new, very low profile balloons we use for CTOs, you can slowly push that under the struts on the jailed wire into the side branch to get back some flow. So you immediately stabilize the patient because the patient is now having chest pain and ST elevation, okay? Once you've done it with a small balloon, you can then go even with a 2.0 balloon. But the trick there is if you're going to use anything smaller than like a 1.25 or 1.5 balloon, you need to put another balloon into the main branch stent, okay? Because you will start deforming the main branch stent by going underneath it. We have one case.
Be able to recross, right?
Yeah, exactly. And then may not be able to recross later, and you turn it then into a mess, right? We had one case once, I remember, where we were doing left main stenting, and we had stented from left main to LAD, and the circumflex went down, okay? And there were three of us, me, Colombo, Flavio Airoldi, you remember, Ricardo. All three of us tried to recross. We couldn't recross back into the circumflex. Big circumflex, patients having massive ST elevation, mitral regurgitation, going into cardiogenic shock, okay, because the circumflex is going down. And what we did in that case, we used the same technique, okay, but we turned this into an inverse crush. So we went slowly with bigger and bigger balloons until we crushed the stent the other way around, okay, so towards the LAD, and then could put a new stent in towards the circumflex. So that's something you can do in very desperate situations as well, is just invert the crush.
Right.
Yeah.
There's a question from one of from Aisha Kader, who is joining us, and she's asking why in the definition trial there were no 101 Medina.
101 Medina.
Yeah, I miss that. I have to say, Aisha, you always pick up things that are, I miss that, because to me it doesn't make any sense why you would
answer, but I think I would confirm this information. Yeah. Azim, do we have some time to show something interesting?
Maybe if you want to show one case, it would be fun just to finish with a case. I don't think we have a lot of time, but I'd love to see one case.
Yeah.
Is that okay?
Yeah, I think we have had some very, very interesting experience at the Visible Heart. I know you have been there as well. So I thought about, showing a case just from inside about DK crush. I think provides some good insights. Why we do every step. I'm just going to go very quickly here in one case, and then I'm going to show it's like a 5-minute video, if you're okay with that. So this is a case, subocclusive lesions, LAD in diagonal. Here, as you can see, this is the big diagonal for this patient. So here we have the steps: pre-dilatation of the side branch. We have stent position. We have a wire. We have a balloon parked in the main vessel. We implanted the stent with the same balloon. We pull back a little bit, and then we optimize here the expansion. Then we pull the wire and the balloon, the side branch. We have the balloon in the main vessel. This is the result. We recross. We do the first kissing. This is the LED stent positioned. We remove the wire back again. Stent implanted. This is a crossing, recrossing, which with the first kissing, it shouldn't be any problem. Then we have the balloon post, the side branch individual post dilatation. We have the LED balloon post dilatation. Then we have the kissing. And of course, you can do here the repot. And this is the type of result you can get, well constructed, reconstructed bifurcation with two stents here. So the visible heart allows us, with some pig models to assess bifurcations and actually see the images from the inside, as you can see here in the mid view. This is the wires going. So here you should consider your side branch. Here you should consider your main vessel, and you can have, OCT. You can have all the what's needed there. So we have here the two wires in both branches, and we try to perform here. We see the step there. So we have stent into the main vessel. I'm sorry, in the side branch, and if you're doing a DK crush, not a nano crush, you're going to have some extent of stent towards the proximal segment of the bifurcation. The balloon is already parked in the main vessel. This is the stent being planted, okay? So this stent is sized according to the distal reference. And we have a gelled balloon here into the main vessel. So it's nice to see these images. So here's the wire being removed from the side branch. You don't want to get the wire trapped there. And then that's the balloon inflated. And this is an important step because it's very likely to have different diameters in the bifurcation from the proximal to the distal main vessel. So if you're sizing, you should do that to avoid dissections. You should size your balloon according to the distal reference. You're not going to have an optimal crush into the proximal segment because it's just a larger diameter there. And if you have that, you should be careful and perhaps perform a pot there. That's like the first pot of the technique. And the first pot of the technique allows you to have a complete crush, so you don't go under the struts with the recrossing of the wire to perform the first kissing balloon. So here now we have a complete crush, and that's where you see the os on the side. So this is a rewire, and that's the step that probably you're going to take. You might take more time, but that's saving your time for the second recrossing, the second kissing balloon. At this particular point, I think going to the distal strut is better because you don't have much metal into the carina area. Here we're having an opening of the os on the side branch. Now we're going to have balloons in both branches, and that's when we're going to perform the first kissing balloon. So why we do this first kissing balloon? You're basically creating a new osteon of the side branch, now a metallic osteon on the side branch, and you are arranging the struts into the geometry of the carina that would facilitate the implantation of the stent in the main vessel. So here, this is after, see how this osteum is completely reconstructed, that this metallic osteum, no excessive struts into the carina segment and completely crush into the proximal segment or the carina. Here, we have stenting now the main vessel. So stenting was easy. Crossing with the stent was easy. After we do that, you're not going to see that type of, distortions that you used to see in the old days. And see here, the ostium, even though it's a gelled ostium, but the construct the new ostium, it's already there. And that's how you facilitate recross. I think here, if you recross around the mid area, mid cell, I think that's how you distribute better the struts into the carina. Of course, we're looking from inside here. From the practical point of view, you just want to do that. But if you have the chance, guiding procedure with OCT and other things, or even by end, you can assess that. I think that's the ideal. We're doing the balloon, individual balloon dilatation into the side branch. I'm going to have now a balloon in both branches. And after optimizing the proximal, the main vessel stent, you can do the kissing balloon. And the kissing balloon here, we have the full reconstruction of the carina. And then you can, at final piece here, you have more like an oval shape here. You can do what they call the repot, which is more in the proximal part of the bifurcation, not at the carina exactly, just to conform and have a round reconstruction. Maybe this has some impact in flow, even though clinical benefit has not been demonstrated. This is the report we are doing here. And we just come here to the end. And I'll just highlight the type of reconstruction that you see, the completely absence of, any distortion, any excessive crushing of the or metallic crushing here or distortions at this segment, the full expansion of both branches and especially the ostium on the side branch. So this is the image here. How we can see this is like a regular stent that we use in clinical practice. And I think it's a good understanding of this technique. So some critical steps, the balloon positioning, once you do to perform the first crushing, this is stent crush. You can be suboptimal. So to do a pot here, then you can have the optimal crush before recrossing to the side branch, and strut rewire more distally might avoid you to have crushing at the carina segment. You want to avoid excessive matter in this particular location. Balloons positioning, this is after the first kissing balloon inflation. So completely new osteum, metallic new osteum, that facilitates the further treatments. This is the pre-pot. This is, this is here after the treatment. This is pre-pot. This is final pot, repot, that you have a much better apposition in the rounding struts here. So I just want to highlight that.
That's awesome. That was worth going overtime for. I love the visible part. Paul Ayatso is just so incredible, and that lab is so incredible. We were actually, I was supposed to take, I was planning to take some of our group there this year, and then COVID hit. But hopefully, as this settles down, I'll be able to get some of our team there.
By the time I was there, I didn't want to leave,
Oh my God, it's so cool. It's very cool. I completely agree. Miguel, any final questions? I just want to say, so a couple of things, about those videos, so that's the one great thing I like about Visible Heart, because when I did a DK crush on Visible Heart, it made me change my practice afterwards, right? And the biggest thing it made me change was realizing that I wasn't completely crushing, okay, when I was doing the first kiss, before the first kiss. And I think you showed that as well. I had exactly the same impression, okay? Yeah. And if you don't completely crush, you can turn the whole procedure into a mess, because then you can go into the stent that's partially crushed. So that was the one thing I learned. The second thing I learned from that Visible Heart is that once you've rewired, okay, if you can't advance the balloon into the side branch for your first kiss, something's wrong. Take out the balloon, don't force it. And probably the two things to do is to recrush and to recross and try a different strut. Because when you see in the Visible Heart, you can cross into things, into the tiniest cells that you would never imagine it's possible to cross into.
Yeah,
Yeah.
absolutely. And I think, that's why it has been described with DK Crush. You can have 3 pots because, the benefit of pot is still, you're going to see there with the new osteo. They reconstruct with the metallic. You can open struts to that. So you can do first to have a full crush. You can have the second to the recrossing, and you can have the repot at the end. So that's exactly what you're saying. That can facilitate the recrossing
Absolutely.
throughout the steps of the procedure.
Mhm. Great points. Yeah. Thank you, Dr. Costa. That was great.
Right. I think that's a great place to end actually. I think everybody's like kind of speechless whenever you see the visible heart. It's hard to say anything after that because it's just so clear when you see it.
Yeah, well, I have to say, just to, as you mentioned already, just say thanks for those guys and Paul and his team. I think they're really making a work that's making a difference for bifurcation left main treatment. We're learning a lot, and this is the type of example of how like bench and animal studies can really help you to change practice, optimize practice. You don't have to learn that with patients. You can learn that, in these models, and then optimize your technique and avoid a lot of problems.
Agree. Ricardo, thank you so much for joining us from Sao Paulo. Miguel, thank you for moderating. It's good to see you. And stay well. I really appreciate it, my friend. Take care of yourself.
Take care. It's a great pleasure. Thank you, and for this kind invitation, and congratulations for this great work you're doing. Thank you.
Thank you so much, Ricardo. You too.
Bye-bye.
Take care. Bye-bye.
Bye.